Good morning, everyone. I'm Diane Perez, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Opioid Use Disorders and Criminal Justice Involvement, a research overview and case study. This webinar is being made available through a collaboration of the Office of State Courts Administrator and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel too. They have been posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 5 to 10 business days. To access the recording, go to www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants within that same time frame. FADA produces webinars and workshops through the support of the Office of State Courts Administrator. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 10 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credit or to access your statement of credit. Do note that the evaluation will close at midnight on Thursday, June 20th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for those persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And now I would like to introduce our presenters. Dr. Tyler Winkelman is an internist, pediatrician, and health services researcher at Hennepin Healthcare in Minneapolis, Minnesota, and an assistant professor in the Departments of Internal Medicine and Pediatrics at the University of Minnesota. He is a staff physician at the Hennepin County Jail He completed his medical school and internal medicine pediatrics residency training at the University of Minnesota Medical School. He obtained a master's degree in health and healthcare research at the University of Michigan through the Robert Wood Johnson Foundation Clinical Scholars Program. Dr. Winkelman studies issues at the intersection of criminal justice and health, with particular interest in Medicaid, substance use disorders, and healthcare utilization. He works closely with Hennepin County on cross-sector data projects that integrate criminal justice, healthcare, housing, and social service data to inform county policy and programs. Dr. Winkelman recently led efforts to implement medication-assisted treatment in the Hennepin County Jail and is one of 2 physicians who treats patients with opioid use disorder while incarcerated. He has written about the impact of the Affordable Care Act on individuals in the criminal justice system and the overlapping epidemics of mass incarceration and opioid use in the United States. His work has been published in JAMA Network Open, JAMA Pediatrics, American Journal of Public Health and Health Fairs, and has been featured on NPR, Time, Forbes, and the New York Times. And now I'd like to introduce Ms. Julie Bauch. She is registered nurse with a master's degree in global health sciences from the University of California, San Francisco. She dedicated to improving the lives of those in her community with innovative and sustainable interventions. She has over 15 years of experience in public health, international health research, and clinical work. Currently, Mrs. Bauch is the Opioid Response Coordinator for Hennepin County in Minnesota. She spearheads initiatives to address the opioid crisis by marshaling relevant research and accurate data to help influence decision-making. She works collaboratively with a variety of stakeholders in a leadership role to develop strategic interventions to further the role of local government addressing this public health epidemic. And now, I'd like to welcome our presenters, Dr. Winkelman and Ms. Julie. I'll turn the presentation over to you.
Thank you, Diane, and good morning, everyone. Thank you for joining us this morning. As Diane said, my name is Tyler Winkelman, and I have Julie Bauch here with me as well.
Hi, good morning, everyone. This is Julie.
And this morning, we are going to review evidence around issues related to the intersection of opioid use and criminal justice involvement. And we're going to share with you some of our experiences in trying to implement opioid use disorder treatment in a county jail. During this webinar, we are happy to answer any questions. We've presented similar slides in other settings around our county, and often there are many questions, and so please just send them at any time, and we will try to address as many of those questions as we can. Here's our outline for today. First, I'm going to cover sort of the overlap of opioid use and criminal justice involvement. I'll talk about the medications that can be used in the criminal justice setting to treat opioid use disorders and some of the evidence backing those medications. I'll talk a bit about some of the co-occurring health disorders that are often seen in folks with an opioid use disorder. And then we will spend a lot of time talking about just what to know about addiction treatment, and then basically the last half of our talk will be focused on our work in Hennepin County and some of our learnings that we think might be helpful in other jurisdictions. Before we get into the meat of the presentation, I think it's really helpful to just go over the definition of an opioid use disorder so that we're all on the same page and are speaking the same language. So when we talk about opioid use disorders, what I'm referring to specifically is the DSM-5 criteria for an opioid use disorder. And so I just want to go through these 11 criteria. So one, opioids are often taken in larger amounts or over a longer period of time than intended. There's a persistent desire or unsuccessful efforts to cut down or control opioid use. A great deal of time is spent in activities necessary to obtain the opioid, use the opioid, or recover from its effects. So I think, as I started to treat folks with an opioid use disorder in the jail, this was one of the criteria that really stood out to me, in that folks really do, spend just incredible amounts of time. This really consumes their life. And that's one of the stories that I've really heard come from our patients, is that this is sort of an just all-consuming disorder that really pushes out other positive influences in their life. There's a craving or strong desire to use opioids. There's recurrent opioid use resulting in failure to fulfill major role obligations at work, school, or home. There's continued opioid use despite having persistent or recurrent social or interpersonal problems caused by or exacerbated by the effects of opioids. There's important social, occupational, or recreational activities that are given up or reduced. Recurrent opioid use in situations in which it is physically hazardous. And then there's continued use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused by or exacerbated by opioids. And finally, the last two criteria are tolerance, so needing to take more of an opioid to achieve the same effect, and withdrawal after cessation of the opioid. And how we classify the severity of an opioid use disorder is by the number of criteria that are checked off by a given patient. And so if 2 or 3 of these criteria are met, that's a mild opioid use disorder. Moderate is 4 to 5, or severe is 6 or more. The indications for medications for opioid use disorder are a moderate or severe opioid use disorder. And these are the criteria that we use at our jail and that I'll be discussing a bit later. In the criminal justice setting, I think our experience is probably similar to what other jurisdictions would note. And that is that the folks that we see in our jail generally check off each of these. And so the diagnosis is not usually a particularly challenging one. I'm sure many of you have seen this slide or a similar slide in the past. This is from the CDC, and these are opioid overdose deaths from 1999 to 2017. And you'll often hear the trend that's portrayed on this graph as a triple wave. And so in the early 2000s, you started to see this increase in deaths related to prescription opioids. That's the darkest green line. Then beginning around 2010, you start to see an uptick in overdose deaths related to heroin. And a few years after the increase in heroin-related deaths, you see a dramatic rise in deaths related to synthetic opioids like fentanyl. So by 2017, there was someone dying of an opioid overdose in the United States approximately every 8 minutes. And this far surpasses sort of the peak of the HIV epidemic, and is now one of the most severe public health epidemics that we've had in the United States. The overdose death rates are likely a conservative estimate because of problems in capturing opioid-related deaths on autopsy and in death reports. And so the numbers are likely worse than this. And we're also starting to see an uptick in deaths related to other substances like methamphetamine as well. We've done some work to try to characterize the overlap of opioid use and criminal justice involvement. And we used a national survey that's conducted by SAMHSA to look at criminal justice and any lifetime history of criminal justice involvement among people with different levels of opioid use. On the screen here, we have 3 categories of prescription opioid use. The first category, no opioid use, then any opioid use, and then misuse. And about 1/3 of individuals who report any past year history of opioid misuse report a history of criminal justice involvement. And as you can increase the severity of opioid use to an opioid use disorder, about over half of people with an opioid use disorder report criminal justice involvement. And among people who reported heroin use in the past year, over 75% reported a lifetime history of criminal justice involvement. And just over 40% of those who reported heroin use reported criminal justice involvement in the past year. And so the real take-home point here is that if you are going to be treating folks who have an opioid use disorder or use heroin, they are very likely to spend time in the criminal justice system, and their treatment is likely to be disrupted unless the criminal justice system is able to help in bridging that treatment. For folks who may be researchers or have spent a fair amount of time in sort of the criminal justice and health space, you're likely familiar with this seminal piece by Ingrid Binswanger, now over a decade ago in the New England Journal of Medicine. This was really the first paper to look at the rate of death after people leave prison, and this cohort was specifically from Washington State. And the real contribution here is that Dr. Binswanger and her colleagues found that folks leaving prison had an extremely elevated risk of death. And that risk was very high in the first 1 to 2 weeks after release. And so their finding was that in the first 2 weeks after release from state prison, the risk of death is about 12 to 13 times higher than it is in the general population. And since this study, there's been a great deal of work to try to dig into this mortality spike and to examine this finding in other settings. Dr. Binswanger and colleagues, a couple of years later, looked at the specific causes of mortality in the weeks after release from prison. And what they found was that the large spike was predominantly due to overdose deaths. And you can see the dark green line in the first week was extremely high. This finding of increased mortality after release from Washington State was replicated in a cohort in North Carolina more recently. And what they found was similar and very striking, that in the 2 weeks after release, risk of opioid overdose death was about 40 times higher among people released from prison compared to the general population. And in the first 2 weeks after release, risk of death from heroin was 74 times greater than in the general population. So it's very clear that overdose deaths are extremely high after release from a criminal justice setting, and that this seems to be replicable across jurisdictions. So how common is treatment in jails and prisons? There's not great data available on this point. About a decade ago now, a team from Rhode Island looked across the country at the number of prisons who are offering different types of opioid use disorder treatment. They found that about 55% of prisons offered methadone at that time, but by far the majority of those prisons offering methadone was primarily for pregnant women, and most of those prisons didn't have robust programs for the overall population. They found that about 14% of prisons offered buprenorphine, and that's not surprising that buprenorphine was less common at that time. We've certainly seen in the last several years an increased number of providers willing to prescribe buprenorphine and folks getting their X waiver. Very few jails and prisons offer all three medications for opioid use disorder. There are over 3,000 jails in the United States, and we don't have great numbers on the number of jails that are offering medications for opioid use disorder. But generally, sort of in the correctional health space, you can kind of list the number of jails that are currently doing this. Although certainly in the last even just 12 months, there's been a fairly steep rise in the number of jails doing this work. And when we think about criminal justice involvement and opioids, it's really important to not just think of correctional facilities themselves. There are a number of other touch points within the criminal justice system that can have a very important impact on access to treatment for medications for opioid use disorder. And there has been work looking at drug courts, and just over half of drug courts offer all forms of medications for opioid use disorder. And so there are a variety of settings within the criminal justice system that could be important touch points to intervene and to increase access to evidence-based treatment. A couple of years ago, folks published a piece in the journal Health Affairs looking at the TEDS data set, which is a national data set of treatment centers across the United States. And one of the variables in that data set is referral source. And so the authors wanted to know, among individuals referred by the criminal justice system for opioid use disorder treatment, what percent received medications for opioid use disorder relative to individuals who were referred from other sources that weren't related to the criminal justice system. And what they found was that for folks who weren't referred from the criminal justice system, who had an opioid use disorder, a little over 40% received medications for opioid use disorder, and just under 5%, so 1 in 20, received medications for their opioid use disorder. And these estimates were significantly different. Examining referral source is a little tricky. So what exactly does that mean? And I think it means that I think there are two important considerations here. One, it's likely that the criminal justice system is perhaps more likely to refer individuals to treatment centers that do not provide medications for an opioid use disorder. And two, there may be conditions of their criminal justice involvement, whether that's probation or electronic monitoring, that preclude a treatment center from providing them with medications for opioid use disorder. And so in the community, folks with criminal justice involvement, at least in treatment centers, are far less likely to receive medications for their opioid use disorder. So that's the evidence around the overlap between opioid use and criminal justice involvement. And now I want to spend some time talking about the different treatment modalities that we can use to treat opioid use disorders. And most of the treatment guidelines that I'll be discussing are based on two sets of guidelines that can be found online. One is on the left, guidance to the states from SAMHSA, the Substance Abuse and Mental Health Services Administration, on sort of standard of care for treatment of opioid use disorders in criminal justice settings. And then the second is a very nice resource that is a guideline that was developed and published last fall. That was a collaboration between the National Sheriff's Association and a national correctional healthcare organization called NCCHC. And both of these are available online and are free and are excellent resources with good background information and sort of recommended standards for doing this type of work in criminal justice settings. So there are 3 FDA-approved medications for the treatment of opioid use disorder: methadone, buprenorphine, which is often referred to by the brand names Suboxone or Subutex, and naltrexone. And specifically, I'll be talking about the long-acting naltrexone, Vivitrol, and not really touching on oral naltrexone, which is a daily medication and has really no evidence for treatment of opioid use disorder. And I want to highlight these graphs that I've included on this slide. So on the right-hand side, you'll see a survival curve. This is of a criminal justice population from Canada who is living in the community but has been convicted of a crime in the past and reported recent criminal justice involvement. And what the authors in this study did was they looked at periods of time when those folks were receiving medication, either buprenorphine or methadone, versus times when they were not receiving medication, this blue line, which is the non-medicated period. And what they found was that there was a very large difference in mortality during those periods of time when people were receiving their medications and when they were not receiving their medications. And that difference was over 15 percentage points. Clearly documenting that for folks who have criminal justice involvement in the community, that receiving treatment dramatically reduces your risk of death. The bottom two graphs show the mortality risk in and out of treatment in a general population for buprenorphine and for methadone treatment. And this is a compilation of data from randomized controlled trials. And again, what they find is that for folks who are in a period where they're being treated with buprenorphine or methadone, the risk of death is dramatically lower. These types of studies, these mortality studies, have not been conducted for Vivitrol, and so we don't have clear mortality data for Vivitrol, whereas buprenorphine and methadone have been prescribed longer for opioid use disorder, and there's clear evidence that they reduce mortality. So I want to spend a little bit of time talking about each of these medications and some important considerations when thinking about what prescribing them means, particularly for folks who are in the criminal justice system or in a jail or prison. So the first medication, methadone, has been prescribed the longest, has been around the longest for folks with an opioid use disorder. It's important to know that methadone can only be prescribed in highly regulated specialty clinics called outpatient treatment programs, or OTPs, maybe colloquially referred to as a methadone clinic. They cannot be prescribed by a primary care doctor or other provider who's not specifically affiliated with one of these specialty clinics. This is particularly relevant for jails and prisons who have to develop strategies to collaborate with these clinics in order to provide methadone in their facilities. Methadone is taken orally daily, can be a liquid or a tablet. As part of the specialty clinic, there's mandated attendance rules, and so you often start in a methadone clinic with daily visits. Generally, Sundays are off, and so you receive 2 doses on Saturday. The treatment information that pertains to the care folks receive in an OTP is protected by 42 CFR Part 2. And so if you are requesting records from a facility, you need to have a consent form that specifically addresses 42 CFR Part 2. And as an example, in our health system, even though the specialty clinic is part of our health system, none of those records show up in Epic. And so you really need to be talking to the client or the patient about which specific treatment program they go to and get the appropriate release, because even if they're in your health system, it won't show up in your medical record oftentimes. And if the patient doesn't mention it, you won't know that they're actually in a methadone program. Methadone's a opioid full agonist, and so it has it fully activates the opioid receptor. What that means is that it can be fairly easily started, so that if someone comes into a jail and has used heroin within the last 24 hours but is interested in treatment, you could start methadone relatively soon. It would not cause them to go into withdrawal. In fact, it would treat their withdrawal if they are in withdrawal. It eases cravings and prevents relapse, and methadone binds very tightly to the opioid receptor, and so at the right dose, it can block the effect of other opioids, so that if someone, say, uses heroin while they're on their therapeutic dose of methadone, it would block that heroin use. There are side effects. There's constipation. There's sedation, particularly when it's mixed with benzodiazepines or some psychiatric medications or alcohol. And there are some sexual side effects, particularly for men. The second FDA-approved medication is buprenorphine. Buprenorphine can be prescribed in a specialty clinic, in an OTP, or by a provider with a DEA-X waiver. And that provider can be a physician, a nurse practitioner, or other advanced practice provider. It's taken under the tongue. It's a sublingual tablet or film, and generally it's taken daily. There are newer formulations that are weekly or monthly doses that are either under or nearing approval or have been approved by the FDA. Buprenorphine may be protected by 42 CFR Part 2, and whether treatment is protected under 42 CFR Part 2 depends on the provider. So if a primary care doctor is providing buprenorphine as part of their general practice, then HIPAA applies. But in addition to HIPAA, if the medication is prescribed by an outpatient treatment program or an addiction medicine specialist, then the treatment is protected under 42 CFR Part 2, and you need that additional language in the consent form to obtain records. Buprenorphine is a partial agonist, and what that means is that it doesn't have the full opioid effect that methadone or heroin or other opioids would have. It also means that if you have a full agonist in your system and you are given buprenorphine, it will cause a precipitated withdrawal. And so folks have to either be in withdrawal or off opioids in order to start. Buprenorphine, once folks are in withdrawal, can treat that withdrawal. It eases cravings similar to methadone and prevents relapse. And it also blocks the effects of other opioids. So again, buprenorphine, similar to methadone, binds very, very tightly at the opioid receptor and will kick other opioids off of that opioid receptor. And buprenorphine has side effects that are similar to methadone. Now, naltrexone is the third FDA-approved medication for the treatment of opioid use disorder. Any provider can prescribe long-acting naltrexone. It's an intramuscular injection that can be given every 28 days. You don't need a special waiver to prescribe it. And again, depending on who the provider prescribing the medication is, it may be protected under CFR 42 Part 2. Unlike methadone and buprenorphine, naltrexone is an opioid antagonist. So what that means is that there is no activating of the opioid receptor, and it just it binds to the opioid receptor and completely blocks it. In order to start naltrexone, a patient must be completely over their withdrawal. Generally would be started somewhere in the order of 7 to 14 days after their last opioid use, depending on the opioid that they were using. This is one of the challenges in administering the medication in the community, is that at the time that someone's interested in treatment, it may be difficult for them to abstain from opioids for up to 2 weeks and to go through that withdrawal. Naltrexone does not treat withdrawal. There are high-quality studies that show that it reduces cravings, and it certainly effectively blocks the effect of other opioids. There are some side effects. There can be some injection site discomfort, and then some patients report nausea in like the first generally couple of days of receiving the treatment. Naltrexone is both approved for opioid use disorder treatment as well as for alcohol use disorder treatment. So one of the questions that we're often asked is, if they're so effective, why do people avoid them? Stigma plays a large role in their use. So there may be employers who don't want employees to be taking time off every day to go to clinic. Generally, outpatient treatment programs have fairly rigid hours and times that you need to arrive, and that scheduling is not particularly flexible. There's certainly stigma within the criminal justice system. Families, other medical providers may have misunderstandings or concerns about treatment, and the folks' peers may not quite know how to best support their friends. There's also lack of easy access for many people, and certainly this varies dramatically in the United States by geography. In many rural locations, access is particularly challenging, and this is borne out in both the literature and I'd say in my own personal experience that there's definitely a fear of forced withdrawal upon incarceration. So as we've already discussed, folks with an opioid use disorder are commonly coming into contact with the criminal justice system. And so if they start treatment in the community, that withdrawal during incarceration is particularly unpleasant. And so that can be a barrier to people wanting to restart their medications. Okay, so those are the 3 medications that can be used to treat opioid use disorder, and are the 3 medications that SAMHSA and NCCHC and others recommend as being available for treatment of opioid use disorder in jails and prisons and in other criminal justice settings. So I've talked a little bit about the mortality benefit of treatment, and now I'd like to focus on evidence for treatment specifically within the criminal justice system. There are far more studies on opioid use disorder treatment in the general population, but in the last 10 years, there have been a number of both observational studies as well as randomized controlled trials of treatment specifically in criminal justice populations. So this first study is by a group out of Australia, and they looked at what the mortality rates were among individuals with heroin use disorder who started treatment in prison versus a group of folks with heroin use disorder who did not weren't started on treatment while they were in prison. And what they found was that for those who started treatment, typically with methadone in prison, their rate of death 4 weeks after discharge from prison was 8.8 deaths per 1,000 person years. And the individuals who did not start treatment while they were in prison, may be told follow up in treatment when you leave, their mortality rates were about 4 times higher at 36.7 deaths per 1,000 person years. The second study comes from a group out of Rhode Island that was published a couple of years ago in The Lancet. And what they looked at was the impact of continuing individuals on methadone versus sort of typical practice, which is forced withdrawal during incarceration. And they were particularly interested in how many people returned to treatment after release. And what they found is that for folks who continued their methadone, nearly all of them, 96%, continued treatment in the community versus about 78% who were forced to withdraw, suggesting that continuation during incarceration dramatically increases treatment retention. This is a study that I think the slide was supposed to be a little later on, so my apologies about that. Is not specifically about the criminal justice population, but I wanted to put this slide in here because data around extended release naltrexone is emerging, and I think it's important to talk about. This was in a commercially insured population, so I had private insurance, and basically they looked at folks who received buprenorphine and looked at times when they were on buprenorphine or not on buprenorphine, and also times they were on extended release naltrexone or not. What they found was that there was a significant overdose reduction for the folks receiving buprenorphine. They found no statistically significant difference in overdose for the folks who received extended release naltrexone. There's one caveat to that, which is that the extended release naltrexone group was quite a bit smaller, and so you can see that this hazard ratio suggests that it trended towards maybe a slight decrease in overdoses, and that maybe did not reach statistical significance because the sample wasn't quite large enough to detect a difference. And then, as I had mentioned previously, the oral naltrexone really has not shown to be particularly effective for opioid use disorder, and this study found similar findings that oral naltrexone really didn't make a difference in reducing opioid-related overdoses. In another study from 2008, a group of individuals in prison were randomized to 3 types of treatment: counseling only, counseling plus transfer to treatment, meaning that they received counseling during incarceration and then said, basically, when you leave, follow up with this treatment provider. And then counseling plus methadone during incarceration. At 6 months post-release, the group who received counseling and methadone was more likely to be retained in treatment. And compared to the counseling-only group, they were less likely to report using heroin and reported less criminal activity. At 12 months post-release, there were significant differences in the amount of time spent in treatment between the three groups. So the group who received counseling only reported about 23 days in treatment after release. The group who transferred to treatment reported about 3 months. And the group who received methadone during their prison stay reported treatment for about half the year after release from prison. The group that received counseling plus methadone also had fewer opioid and cocaine positive urines. And there have been other studies that indicate that it may be that for folks who are co-using stimulants, that while medications for opioid use disorder don't specifically treat the stimulant use, there have been other studies that have found that stimulant use may go down slightly in folks that are being treated for their opioid use disorder. We don't have a lot of data comparing buprenorphine to methadone head-to-head, particularly in criminal justice settings. There was a group at Rikers in New York City that did look at outcomes for folks who received either medication at Rikers. And what they found was that there was no difference after release in self-reported relapse or criminal activity between either group. Buprenorphine has been compared to counseling alone, and for folks in the criminal justice setting. And what that study showed is that folks who received buprenorphine as opposed to counseling alone had much higher rates of treatment upon release compared to the counseling group only. And then there has been one study of long-acting naltrexone versus counseling and referral among a justice-involved population. And what that study found was significantly lower rates of relapse at 24 weeks in the long-acting naltrexone group, 43% versus 64%, and no difference 1 year after treatment. So these are sort of my take-home points for where the literature is currently at with regards to medications for opioid use disorder in the criminal justice system. One is that forced withdrawal during incarceration reduces treatment entry after release. That's pretty clear and has been documented now in a number of studies. What is also clear is that starting medication during a period of incarceration is superior to a community referral or counseling. Results between buprenorphine and methadone are similar, and I don't think there's enough evidence to say that one would be superior over the other for folks who are in jails or prisons. And naltrexone does appear to be effective compared to a placebo or compared to counseling. There was recently a study in Annals of Internal Medicine that compared the cost effectiveness of extended release naltrexone to buprenorphine and suggested that it may not be cost effective given the much higher cost of naltrexone relative to buprenorphine. So there's good evidence that treating folks with medications for their opioid use disorder is effective. So I wanted to spend just a little bit of time on Rhode Island and the work that they've done over the last year as an example of what might happen if your jurisdiction were to implement such a program. Rhode Island is a unique state from a criminal justice perspective because it's a unified prison and jail system, meaning that all correctional facilities are under control of the same authority, so that a change in one change dictates change across the entire system. They implemented an opioid screening and treatment program at the end of 2016. And what they did was they assessed post-release mortality in early 2016 compared to early 2017 after their system-wide changes. And they published these findings in JAMA Internal Medicine, which is one of the premier medical journals in the United States. And what they found was quite remarkable. They reported a 60% reduction in post-release mortality. And this reduction in post-release mortality was so large that they noted an overall 12% statewide reduction in opioid overdose deaths, going from 179 deaths in the beginning of 2016 to 157 in the beginning of 2017. And this was at a time when fentanyl was really ramping up and was causing a higher number of deaths in surrounding states. And there's a statistic in medicine that we often use that's number needed to treat. So how many people do you need to treat in order to save one life? And they found that for every 11 patients that they treated, one life was saved. And this is my last slide before we take a short break. This is to highlight the co-occurring health issues among folks with opioid use disorder. And that if you are treating folks with an opioid use disorder, you should expect that there will be other health issues that need to be addressed. Among a national sample of individuals with opioid use disorder, we found that sexually transmitted infections were about 4 times more common among folks with an opioid use disorder compared to the general population. As many of you are familiar, hepatitis C and HIV are much more common in individuals with an opioid use disorder. And other chronic conditions like COPD, diabetes, asthma, heart disease can be more common. And when individuals enter treatment for their opioid use disorder, it may be the first time that they have seen a provider in years. And so in addition to addressing the opioid use, you will likely need to also be either addressing their physical and infectious complaints or referring them to treatment for those issues as well. And then finally, co-occurring mental illness and severe mental illness in particular is much more common among individuals with an opioid use disorder, up to 7 times more common based on some of our estimates. So this may also be a time when individuals are also re-engaging in care for their mental health. It's not uncommon that folks are starting medications for their opioid use disorder or starting medications for their mental health, and particularly if they have a severe mental illness like schizophrenia, may be starting on medications that also have side effects. And so this is an important thing to keep in mind as you assess how treatment for their opioid use disorder is going, in that if they're experiencing some drowsiness or sleepiness or other side effects, that it could be that it's their opioid use disorder treatment, but often it's these other medicines that they're starting at the same time. So with that, I think we have a 5-minute break to get up and stretch your legs, and then we will come back and focus primarily on the work that we're doing here in Hennepin County and talk to you a little bit about how we've gone about implementing a program in our early experience. And if you have questions during the break, feel free to plug them in, and we're happy to answer them in the second portion. And we will be back in about 5 minutes.
Hello, everyone, and welcome back to today's webinar. Dr. Winkelman, are you ready?
We are ready.
Awesome.
All right, so the second part of this talk will be about our work in Hennepin County, and I am going to hand off the next several slides to my counterpart in Hennepin County, Julie Bauch.
Hi, everyone. Thank you, Dr. Winkelman, and everyone who's listening. My name is Julie Bauch. I am a nurse by training. I've been a nurse for over 15 years in quite a few different capacities, all which have led to this very unique position that I'm in now, which is called the Opioid Response Coordinator for Hennepin County. I started as a nurse in the emergency department, so I saw a lot of individuals with opioid use disorder coming in with overdoses and using Narcan in that way and in that setting. I was an ICU nurse, and so took care of people who had opioid use disorder and substance use disorders who were severely ill from sundry of different reasons for their use disorders. And then I started to work in public health. I was working with healthcare for the homeless. So I was on the streets and in the shelters and really seeing firsthand a lot of individuals who had opioid use disorder and other use disorders in that way. I work for Hennepin County government in the Department of Public Health. Hennepin County is the biggest county in the state of Minnesota. It encompasses the city of Minneapolis and the north, west, and south suburbs. It does not include the city of St. Paul. That's a different county. And we have the largest, like I said, the largest population by county in the state, with about 1.4 million people in our county. So the way that this role that I'm in came about is fairly unique. Our Board of Commissioners for Hennepin County in 2017 stated that they wanted a full county-wide opioid strategic framework. They wanted a county-wide opioid response. So the Department of Public Health director, she really took the lead and said that public health would create the opioid prevention strategic framework and would gather individuals from every single department in the county, and that they would write this strategic framework together. So all of this was happening in 2017. They had about 42 original authors and people at the table, and it included people from the courts, from the sheriff's office, from the libraries, from public health, human services, the corrections facilities, attorneys, prosecutors, defenders, epidemiologists. So the original framework had really a robust authorship that contributed to what everybody thought that their role was to address this crisis in our community. The framework was presented back to the Board of Commissioners, and they approved our strategic framework in January of 2018. In the framework, and I'll show this in a little bit, there are 3 pillars, and within these 3 pillars that we address, there are 32 action items. So what the Board of Commissioners said then was that they approved to hire somebody to implement this framework. So I was hired in May of 2018, so just a little bit over a year ago. as the opioid response coordinator to implement this 32 action item framework that has county-wide implications. I created an opioid steering committee, and it was many of the original authors, but a much smaller group of decision makers and influencers within the county who could work with me to make sure that we were on track with the implementing the strategic framework and moving it forward as originally intended. So, you know, the focus is on opioid prevention, but we know that anything structural that we put in place and implement has effects on substance use disorder as a whole, more broadly. Much like many opioid responses that you see, our 3 pillars are primary prevention, to prevent further spread of the opioid crisis, response to overdose deaths, and treatment and recovery, to provide recovery services. I'll give you a few examples from each. I won't go through all 32 action items, but I'll give you a few examples of things that a local government can do. So for primary prevention, really some of the biggest things we're focusing on is creating a robust integrated data team, much like, you know, most jurisdictions and most systems. Public safety data does not interface or interact with public health data, and they don't share the same interface as human services data. So I have a data coordination team so that we have interdisciplinary look at the opioid crisis in our community from all of these different angles that the crisis affects. Another thing that we do in prevention is medicine drop boxes. The county sponsors about 17 medicine drop boxes throughout our county that we maintain and service in public spaces for people to dispose of medicines from their homes that they don't want. And then we work in public-private partnerships with about 17 other private entities like CVS's and Walgreens and other pharmacies. They run their own medicine drop boxes, but we work in partnership with them to have them set up and maintained and advertised to the community that they have those services. For response, we have quite a few initiatives. One of them is that all first responders in Hennepin County are trained on carrying Narcan and carry it. So that means the sheriff's office, police departments, fire, and EMS. We run needle exchange and Narcan distribution out of our public health clinic. And then treatment and recovery is really something that I'm going to focus on when we bring Dr. Winkelman back to talk. It's something that we've worked on together quite a bit, especially in the jail and incarceration setting, where one of the action items in treatment and recovery is providing medications for opioid use disorder in the county-run jail and the county-run corrections facility, which is longer term, up to 1 year. So I'll just show you briefly, you know, the collaborations across the line of business that I do. That includes, of course, Sheriff's Office, Human Services. Hennepin Healthcare is the local safety net hospital where Dr. Winkelman works. The Department of Corrections, Facilities, Communications, Environment and Energy, our intergovernmental relations team, which I work closely with our lobbyists, and we follow state and federal policy that we lobby for. And then, of course, our legal delegation working with the courts, the judges, prosecutors, and defenders. So not only do I work within Hennepin County and all of the departments that our local government runs, but I work very closely with our partners outside of the county. That includes the state, the cities, specifically the city of Minneapolis, our communities, which is vital to understand community resources, community clinics, not-for-profits, faith-based organizations and schools who are also experiencing the opioid epidemic, and providers much like Dr. Winkelman and his colleagues who are in the community in these spaces addressing the opioid epidemic from a medical standpoint. So I'm going to leave this photo of a sheriff's deputy showing us his Narcan while I talk a little bit about how all of our relationships among the county and the departments and disciplines within the county interact with the hospital, and how we really relied on these relationships to change policy. So one thing that I want to point out is that the work that I have been doing from the county's perspective with Dr. Winkelman in the criminal justice field of those who are in jail is just one part of the larger response strategy for Hennepin County. And I think Dr. Winkelman will touch on this a little bit later with some of his slides, but it's really unique to work with the criminal justice system within a county because the sheriff's office is run by an elected official. And those elected officials then appoint their chiefs and chief deputies. So I think one of the main takeaways that we have both understood through working through this for about a year is that elections really matter. And it matters to understand those who you're electing and those who are running, to really research and understand their stance and viewpoint on the intersection between public health and public safety, and how those disciplines work together. So who approached who, and how did we get this work to go together? Well, I started this role a little bit over a year ago, and I was lucky enough to have an already established relationship between Hennepin County Public Health and Dr. Winkelman and his colleagues. So when I took this position, there was already a lot of motivation and excitement around one person who was coordinating all of these efforts, because there were already physicians and researchers who were interested in this topic. So I used my relationships in public health, some epidemiologists who I knew, and it was connected almost immediately on day one with Dr. Winkelman and his colleagues at the Addiction Medicine Clinic. Because I work at Hennepin County, I work extremely closely with the sheriff's office, not only the sheriff, but his chief of staff and his administrative staff, who are who contributed to the original framework and who sat on my steering committee. So I spent quite a bit of time getting to know new people in this role and establishing relationships and understanding shared goals. And I think that is truly one of the keys to success to getting this work done, is the establishing of relationships and understanding that we have shared goals that we're working towards. So we're going to talk about this more. Dr. Winkelman and I will get into the research and the work that we've done. But really how this came about is that because I know people who worked in corrections and the sheriff's office, and because I had a connection with Dr. Winkelman and his colleagues, basically we we got together at a table and started talking about anecdotes that we've heard. And one of the anecdotes that we heard was that people are released from places of incarceration and are overdosing and dying at really high rates. So our first order of business was to do the research, to quantify if the anecdote was true. And really what makes working with criminal justice entities successful is, like I already stated, was just listening to their point of view, which is their point of view from their vocation and their discipline, which is public safety, and understanding how that overlaps with similar goals from public health and from clinical services, and that we're seeing the same things but from very different angles. So I actually think at this time I'm going to hand it over back to Dr. Winkelman, because he's going to get into the partnership that was created, the research that we did, the policy that we wrote, and the steps that it took to share with stakeholders and elected officials and then the media to describe the work that we were doing in the jail and the places of incarceration.
Thank you, Julie. So as Julie said, the first thing that we did on our trajectory to start treating opioid use disorders at the Hennepin County Jail was to just look at the current state of affairs in our county. And we were able to link mortality data with jail and prison data across Minnesota from 2015 to 2016. In Minnesota, these are publicly available data and are easily accessible. And what we wanted to know was what is the impact of the criminal justice system on Hennepin County residents, and what's the impact of Hennepin County facilities on all Minnesota residents. Earlier in this talk, I touched on the high risk of death after release from incarceration. And so we know that that happens in other states, but there's something particularly powerful of actually seeing the numbers in your own backyard. And sometimes it takes seeing the data to really believe that it's also happening in your community. So what we found and what we have shared over the last 6 months across the county and across the state are the following data. First, what we found is, Minnesota is a concentrated state where a large percentage of the population is in Hennepin County and the surrounding area, and then the remainder of the state is relatively rural. That about a third of the opioid overdose deaths were occurring in our county. Both among deaths in our county and in opioid-related deaths across the state, about 30% were occurring within 12 months of release from prison or jail. So said another way, approximately 1/3 of overdose deaths happen in the year after release from prison or jail. And what we found was that when folks die after release, it's most often happening in those first 3 months. We also found that our correctional facility, the Hennepin County ADC, or the Hennepin County Jail, was having a relatively large impact statewide. We found that across the entire state, about 10%, 1 in 10 opioid deaths occurred after release from our jail. Minnesota is unique in that there are substantial disparities in overdose deaths among African Americans and Native Americans. And we also found that most of the stays prior to death in the jail were longer than 24 hours, suggesting that we had time to intervene. So we made 3 recommendations. First, that universal screening for opioid use disorders was warranted during periods of incarceration in Hennepin County. That individuals should have the opportunity to continue or start treatment for opioid use disorder during a prison or jail stay. And that individuals should be linked to community treatment upon discharge. So we released this report in January after some internal discussions with the sheriff's office, and nearly immediately after the report was released, we're able to start implementing this program. And so what I will share with you is sort of our experience in starting from scratch to put these recommendations into practice. As I said, we began treating opioid use disorders earlier this year. And our current team includes 2 physicians who have their DEA X waiver. The Hennepin County Jail has intake nurses that do an intake assessment on anyone admitted to the jail. And those nurses now include in that intake an opioid use disorder questionnaire that we have made very simple and that will flag anyone who reports using prescription opioids, heroin or fentanyl, or using or who is currently in a methadone clinic or receiving buprenorphine in the community. We have a nurse care coordinator at our jail who has traditionally connected individuals with severe mental illness or chronic physical health conditions to care upon release, and has generally focused on our highest risk patients. And he was able to carve out some of his time to help us with care coordination upon release. And then the jail nursing staff, physically deliver the medication to patients during their normal rounding in the jail. So in our program, folks can be continued or inducted on buprenorphine during their jail stay. And we've recently begun offering naltrexone to folks. And I will talk a bit more about our work around methadone in a slide or 2. So our criteria are similar to the DEA indications for treatment of opioid use disorders. Patients must meet the criteria for a moderate or severe opioid use disorder to be inducted at the jail, so in order to start treatment if they're not already on treatment. But as I said previously, I've yet to have a patient who didn't meet criteria for a severe opioid use disorder. And for the folks that we're starting, they've often been using heroin or fentanyl, for several years, and many of them, it's the first time that they've really not been injecting opioids, and so as they enter treatment, sort of the change happens almost in front of your eyes, and it's pretty amazing. We will start individuals on 8 milligrams of buprenorphine. Generally, we give them 4 milligrams as a test dose and then an additional 4 milligrams on the first day. In the community, many clinics will actually do home inductions where the individual picks up the prescription, comes into the office, may take the first dose in the office, and then can take additional doses at home until they feel like they've hit the right dose. That obviously cannot be done in a jail or prison setting, and so we have criteria and a protocol for up titration that does not happen quite as quickly as it likely would in the community, but we do titrate up to 24 milligrams so that folks aren't going into withdrawal towards the end of their dose and have their cravings relatively well controlled. We use the just monoproduct buprenorphine or Subutex during the incarceration stay instead of Suboxone. That's partly because of cost. It's partly because our concern that folks would be able to inject the medication and divert it is very low. It's monitored by nursing staff. When we use the monoproduct, it's able to be crushed and then given to the patient under the tongue, and this helps to reduce diversion and reduces the time it takes for the medication to dissolve. And then for folks who leave our facility to the community, we refer individuals to our addiction medicine clinic if they're interested, to community clinics who provide buprenorphine, to residential treatment centers, or if we think that they need a higher level of care than outpatient treatment, but not residential, we can also and have referred to outpatient treatment programs or methadone clinics. So we most recently sort of did an opioid check of sort of the burden of opioid use in our county jail in April. These are just raw numbers of people in our county jail who are monitored for opioid withdrawal by month. So generally between 150 to 200 individuals per month are monitored for opioid withdrawal. It's a little under 10% of admissions at our facility. It's a couple thousand people per year who are potential candidates for treatment. And to give you some sense of how our program has ramped up in the most recent months, you can see that numbers of individuals receiving any type of buprenorphine was relatively low prior to January and primarily encompassed pregnant women who entered the jail with a buprenorphine prescription, and then has started to increase fairly quickly in the more recent months. And we've now, as of today, I think treated close probably to 70 patients. So this is just a bit more about what we actually do at our jail in order to start someone on treatment for their opioid use disorder. All medications are reconciled upon admission. So for individuals who are already on treatment, the nursing staff will let me know that there is someone who reports a active prescription for buprenorphine, and then I'm able to look in our state's PDMP, confirm that they have been receiving regular prescriptions for buprenorphine, and then continue to prescribe it in the jail. For those folks who have a very spotty history and maybe just a couple of weeks of buprenorphine prescribing, I will often choose to see them in my clinic as well. So for folks who have never received treatment before, we see them in clinic in the jail, and we conduct a full history and physical. We obtain a thorough social history about their history of substance use, their housing status, their employment, and in-depth information about their additional medical problems and any other medications that they're taking. As I said, we generally will provide individuals with 4 milligrams of buprenorphine initially, followed by another 4 milligrams 30 minutes later. We do get a very clear history of when their last opioid use was, and to make sure that we avoid a precipitated withdrawal. We haven't had anyone who's experienced that precipitated withdrawal at our jail. And it's also important to ask about any opioid use during the incarceration itself, and certainly do not assume that they haven't used any opioids since their incarceration. It's important to review the prescription drug monitoring program to see if they've previously received buprenorphine or any other opioids, or any other substances that could interfere. I know the Minnesota PDMP also includes benzodiazepine prescriptions and a few other medications. The labs that I consistently check for everyone who is being inducted is a liver function test, a hepatic panel, HIV testing, and hepatitis C testing. I would say that the national estimates of the overlap of hep C with opioid use disorder, I'd say, are conservative for the population that we see in the jail. I would say that more than half of the folks we treat have hepatitis C. We do have folks sign a contract who are being inducted at the jail, and I would say that the primary way we use it is for educational purposes, to explain how the treatment works, to explain what the patient should expect, so that they know what the expectations will be of the provider in the community, and the types of tests like urine analysis that they may need to undergo, and use it as a time to really understand what the patient's goals are for treatment. As part of our contract, there is sort of a fill in the blank section that we have patients actually write out their goals for treatment. And I've found that to be a particularly helpful way to engage patients and to talk about expectations surrounding their treatment. We have Epic in our jail, which is, I think, probably a novelty compared to many jails across the country. And so we are able to sort of create lists that auto-populate so that we can keep track of the number of people we're prescribing to stay in compliance with the DEA regulations around how many individuals each physician can prescribe to at any given time. And then we also allow generally up to a week of medication upon discharge to give people time to connect to their outpatient clinic. So these are some rough estimates of where we were at in about April. About 47 patients had received treatment, 39 were continuations, and 8 patients had been started. And of those 47, 8 patients were transferred to the post-sentencing Hennepin County Jail, which is called the Adult Correctional Facility. And so anyone who's pre-sentencing in Hennepin County is at the Hennepin County Jail, and then if they're sentenced and have a jail stay, they go to the Adult Correctional Facility. And that facility is not, the healthcare is not operated by Hennepin Healthcare. It's operated by a private healthcare company. And we have, both Julie and I have, Julie has, I think, helped us form a collaboration with their medical team. And our team works very closely with that jail medical director to make sure that our protocols are similar so that transfer between facilities goes smoothly and that treatment isn't interrupted. So of the folks who had left our jail in April, 29 remained in treatment when we had last checked, and 11 patients were no longer in treatment. Of the folks who were no longer in treatment, most went to other counties that did not continue treatment. But I would say that since we have started treating folks in our jail, we have heard of several jails in the area that have asked their physicians to become waivered to continue individuals on buprenorphine that we either continued or started at our jail. And so there definitely seems to be a sort of contagion around treatment once at least one jail kind of gets started with this. And so at least over 70% of our patients who we've provided some treatment, either continuation or started, have continued with their treatment after release. And when we started, we certainly prioritized patients who, seemed like they would be able to continue treatment after release. And but we're very happy that it seems that the majority of folks who we're providing treatment to are able to stay connected to care upon release. This is certainly a work in progress, and we are learning as we go. One of the most important pieces to our work has been work around nursing education. At our jail, there are about 30 nurses on staff, many of whom have worked at the jail for, over a decade. And so this is a really new thing, and a paradigm shift. And for most people, whether they're nurses or physicians or other health professionals, they likely have not received great training around addiction, either while they were in school or as part of their ongoing continuing education. And so the same concerns and stigma that exist in the community often exist among health professionals. And so it's really important to clarify with the staff who are actually carrying out the day-to-day activities what the evidence is, why the program is happening, and to really be clear about how the program is expected to unfold. And so we have both formal seminars that we do for all of the nursing staff, and as this unfolded, I had listening sessions where I would be available for an hour on a given day to just sit in the nursing lounge and answer any questions people had, to understand sort of what they were seeing unfold, how things were going. And it was really helpful, I think, for me as well to hear sort of what nursing was noticing for folks who were engaging in our program. And I would say that overall the experience has been very positive, and many nurses have commented that they think that behavior in the jail has improved, and that while we're engaging more patients, they feel like some of their workload is actually easier. In collaboration with Julie, we have done a lot of community outreach and partnership development with local community clinics. We worked with local media to discuss our report, and as part of that media outreach, clinics actually contacted us to participate in continuing treatment upon release, which was unexpected, but we now have a list that Hennepin County puts together of clinics that are available for folks in the criminal justice system to get treatment. And then we have received some state funding through a federal grant to expand our program. And we are expanding by adding a social worker to help folks connect with social services. We are going to be adding a nurse practitioner to help with prescribing, a peer recovery specialist with lived experience to help people with navigation upon release, and an additional nurse care coordinator. And we think that this larger team will allow us to further expand treatment. And I just would say that if you're interested in starting these programs, there is a lot of funding out there, and now is a good time to be looking at opportunities to expand your resources. We are developing telemedicine visits so that a physician doesn't need to be actively on site to start someone on medication. And we have just done that one time so far. And we're in the process of contracting with an outpatient treatment program to continue individuals on methadone. Federal regulations prevent the primary care doctors from continuing that medication longer than 3 days. And we hope to have that process put together soon. But for us, that has been remarkably challenging to just get through the complicated regulations around who can prescribe methadone and that is moving forward, but not quite as quickly. And then we have also, again, in collaboration with Julie's office, done a good deal of outreach and just educational seminars for public defenders, county attorneys, and other law enforcement officials. So a few tips for success, in our opinion, are to really, this is, I guess, speaking as someone in healthcare, to partner with key county partners and officials. It is, I tell people, I thought the healthcare system was complicated until I started learning about the criminal justice system. And it really does take collaboration with folks who understand that world and who can help connect across these multiple public sectors to make a program work. And so the more you can partner with other individuals in county government, I think the easier your task. We have found it extraordinarily helpful to use local data to inform decisions. And it really seemed like policymakers were able to organize around our report when it came out and gave folks a tangible data point to start from. And so I'd really encourage folks who are interested in doing this, who may be hitting roadblocks, to try to get whatever data you can to help inform that discussion. Obviously, we have the endorsement of our sheriff's office, which is critical, and I'm going to talk a little bit more about that. I had never prescribed buprenorphine up until 6 months ago, and so finding experienced physicians to help with your protocol development and troubleshooting as you get started is important. And I can't stress enough just how important the care coordination piece is. I think that one of the most important pieces is this care coordination. And then the Medicaid enrollment post-release is also critical. We have a question here. How do you pay for ongoing care, both medication and psychotherapy? So, while someone's incarcerated, obviously that falls under the sheriff's office. Upon release, it's unclear to me when someone's Medicaid is terminated, but we are a termination state. So at some point, if you're in jail long enough, your Medicaid gets terminated. I think our statute that it's supposed to be on day one. It generally doesn't happen on day one. And so we're lucky enough that the safety net health system is a couple blocks from our county jail. So if someone's Medicaid is terminated, we can have them follow up at the hospital and actually enroll in Medicaid that day, and they're able to refill their buprenorphine. If they are released sort of unexpectedly or not during business hours, it can be incredibly problematic. And so sometimes they do need to pay out of pocket if they have the funds. Otherwise, there may be a gap until they can come in the next day to enroll. And we do put information about where to enroll in Medicaid in their property in case they leave unexpectedly and we're not able to help them enroll. There's another question here about after release, do you show more success with methadone or buprenorphine patients? That's a great question. We primarily are continuing people on buprenorphine. We have not been able to sort of address the regulations yet around methadone continuation, and so we're hoping that will start in the next month or so. For patients who are in methadone treatment, we are able to transition them to buprenorphine. That takes a few days of a washout period. And so we do not have that that option. A few points of just engaging with the sheriff's office. I found it really helpful, again, to collaborate with other partners who have worked with the sheriff's office in the past and have a working relationship with the sheriff. One of the things that we initially did in working with the sheriff's office is to really understand what's most important to the sheriff's office. And we've really, in our discussions, tried to frame addiction as a public health problem and medications for opioid use disorder as standard of care. And as Julie said, it's unlike many of the healthcare systems that we work in, you're working with elected officials, and so there's sort of a, an elections matter piece to this, and wanting to work or support officials who will engage with health professionals and with best practices. A few months ago, sort of a landmark report was released from the National Academy of Medicine entitled Medications for Opioid Use Disorder Save Lives. And one of the key conclusions of that report was that medication-based treatment is effective across all treatment settings studied to date, and that withholding or failing to have available all U.S. Food and Drug Administration approved classes of medication for the treatment of opioid use disorder in any care or criminal justice setting is denying appropriate medical treatment. This is a pretty forceful statement, and I think is helpful in engaging other stakeholders, as this is an agreed upon evidence-based standard of care that should be incorporated, just like we incorporate insulin treatment for patients with diabetes. The last two slides of content are sort of frequently asked questions that we have gotten from attorneys, judges, other criminal justice stakeholders as we've rolled out this program. And I don't think we'll have time to touch base on them, but I do think I want to just briefly mention that how I approach addiction is really describing it as a chronic disease, that similar to diabetes, there are medications that can be used to treat it. Just like diabetes, we encourage lifestyle changes for everyone, but just as many diabetics may not change their diet, folks with an addiction may not completely change their behavior. But because they don't do exactly what you say does not mean that we still don't use medications that we know are effective in reducing the morbidity associated with that disease. There's one final question: how does the program impact pregnant patients? And our program in the jail does offer buprenorphine to women who are pregnant, and so we are able to either continue folks or start them on treatment if they are interested, and then we are able to refer them to our obstetric providers. So in closing, the conclusions of that I hope you'll able to take away are that criminal justice involvement is common among individuals with an opioid use disorder. Release from jail and prison is associated with a very high risk of overdose deaths. Opioid use disorder treatment in the criminal justice system is effective. Treatment programs in jails and prisons require lots of communication and collaboration, and resources to help with the transition from jail to the community are critical. So with that, I just want to thank you all again for participating in this webinar today. This, again, is a fairly high-level overview. I hope it was helpful for you all, and please don't hesitate to reach out to either Julie or myself if we can be helpful in any way. So thank you so much.
Thank you, Dr. Winkelman and Ms. Julie, for your time today and your knowledge and sharing your knowledge with us. When we conclude today's webinar, your browser will take you to an evaluation on FADA's website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost, and that is at the bottom of the list. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email. The sender will be Messenger at WebEx. Evaluation will close at midnight on Thursday, June 20th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Office of State Courts Administrator for funding today's education. Have a great rest of your day, and please hold for the evaluation.